This is a quick video talking about neuromodulation and how it is used on nerves that innervate the heart. This is my summary of neuromodulation, week 9 from Macquarie University. The topic is cognitive neuroscience, Sci 354. To begin with, neuromodulation is the altering of nerve activity at certain sites through electrical or chemical stimulation. It alters communication between pre- and post-synaptic neurons, and they can either be inhibitory or excitatory. So as a refresher, there's the autonomic nervous system, which evolved in involuntary regulation of visceral functions. There's the sympathetic nervous system, as a part of the autonomic nervous system, and this is basically the fight or flight pathway. There's also the parasympathetic nervous system, which maintains normal function, such as, for example, resting and digesting. These sympathetic and parasympathetic nervous system pathways differ in 3 ways. In that, one, they have different lengths of pre- and post-synaptic neurons, whereby the sympathetic nervous system has short pre-ganglionic neurons and long post-ganglionic fibers, and as a result it is easier to stimulate the post or efferent ganglia area. There's the parasympathetic pathway, which has long pre-ganglionic neurons and short post-ganglionic fibers. With this, it is easier to stimulate the pre- or afferent fiber ganglia. The other way, or the second way that the sympathetic and parasympathetic fibers differ, includes the type of neurotransmitter that they use. For example, the pre-ganglia relies on acetylcholine for the sympathetic, and its post-ganglia relies on norepinephrine or noradrenaline. The parasympathetic, on the other hand, in both pre- and post-ganglia relies on the use of acetylcholine. Finally, the sympathetic and parasympathetic differ due to the location of the preganglionic neurons, whereby in the sympathetic neurons, the pre-ganglia neurons are located in the spinal cord, whereas the parasympathetic neurons, their ganglia is located in the brainstem. Their preganglia is located in the brainstem. Now, for most of this video, I'll be talking about the regulation of the heart rate and how neuromodulation is used to, neuromodulate the heart. The regulation of the heart rate can be done in the sympathetic and parasympathetic nervous system to innervate the sinoatrial node. So in the sympathetic nervous system, when it is activated, it increases the heart rate, and it is activated by the neurotransmitter noradrenaline or norepinephrine. Its receptors consist of beta adrenoceptors, and adding atenolol causes bradycardia, or when the heart is less than 60 beats per minute. So as in, adding atenolol has the opposite effect of the sympathetic nervous system because it decreases the heart rate. The preganglia of the sympathetic nervous system consists of the intermediolateral cell column, which is from the spinal cord, whilst the postganglia of the sympathetic nervous system is the inferior cardiac nerve, also known as the stellate ganglia. The parasympathetic nervous system, on the other hand, when activated, decreases heart rate. It relies on the neurotransmitter acetylcholine, and its receptors consist of the MACH receptors, or muscarinic acetylcholine receptors. Adding atropine causes tachycardia, which is when the heart beats at 100 beats per minute. Also, another thing to note in regards to MACH receptors is that it is tonically active, which implies that the MACH receptors are always in control. The parasympathetic preganglia consists of the nucleus ambiguus and the dorsal motor nucleus of the vagus nerve. There is also the brainstem. The postganglia of the parasympathetic, however, consists of the vagus nerve, which is a fat pad on the heart, and this is the parasympathetic's efferent. To controlling how fast the heart beats. Another important thing to note is the equation of MAP equals TPR times CO. All cardiac output results from stroke volume, which is the blood pumped from left ventricle per beat, and the heart rate. MAP stands for the mean arterial resistance. TPR, however, stands for total peripheral resistance. So this is the resistance of the much smaller blood vessels. Well, it's the total resistance anyway. And CO is the cardiac output. Normal blood pressure sits around 120 to 180 BP. The sympathetic nervous system controls the regulation of blood pressure, which stands for BP, or BP stands for blood pressure. And this occurs via the TPR, the total peripheral resistance that I've mentioned prior. It controls the diameter of the blood vessels, and it innervates the postganglionic ganglia to the heart, which changes the cardiac output as a result. So the sympathetic nervous system basically always narrows the blood vessel diameter and increases resistance, thus innervating the vasculature and changing the TPR, the total peripheral resistance. Topographic arrangement. Another thing to mention is topographic arrangement, which is when the sympathetic ganglia innervates the upper spinal cord and as a result controls blood vessels in the head and the neck. And the sympathetic ganglia also innervates the lower spinal cord, which as a result controls the lower limbs. The arterioles are major resistance vessels which are heavily innervated by the sympathetic nervous system by alpha adrenal receptors, and this affects the blood pressure and the total peripheral resistance. In addition, there is the baroreceptor reflex, which reacts to the sudden change in blood pressure, helping to keep blood pressure at around 120 to 180. Any deviation harms the body, and thus the baroreceptor reflex increases blood pressure by increasing the reflex activity, increasing the carotid sinus activity, which enters the medulla. And if the blood pressure is too high, it is decreased by reducing this reflex activity. It can change the vagal and sympathetic outflow to the heart and vasculature, and the carotid sinus enters the medulla via two tracks. The first track is the nucleus ambiguus, which goes directly to the heart, and the second track is the CVLM to RVLM. The CVLM stands for the caudal ventral lateral medulla, whilst the RVLM stands for the rostral ventral lateral medulla, which goes to the stellate ganglion and heart via the paravertebral sympathetic chain ganglia, which controls the arterial resistance vessels. So the purpose of neuromodulation is to understand the function of the nerve and how disease changes the function. In cardiovascular related diseases, the heart rate is elevated from increases in the sympathetic nervous system tone and a reduction in the parasympathetic nervous system tone, or it could be from both, increase in S and S and decrease in P and S. Optogenetics is in vivo optically stimulated nerves via channelrhodopsin's EYFP on nodose petrosal ganglia, and I've covered optogenetics before in a prior video which you can check out in the link up there. So in continuing about the issues in the heart, there's autonomic dysfunction, which reduces vagal tone and increases the sympathetic nervous system activity, reducing the baroreflex. This causes hypertension, heart disease, arrhythmia, obesity, diabetes, kidney disease, sleep apnea, depression, schizophrenia, etc., etc. So a question to ask would be, how would one restore the autonomic nervous system activity via neuromodulation? Well, one could use vagal stimulation to correct the reduction of the reduced vagal tone. One could also use the stellate ganglionectomy technique, which reduces cardiac sympathetic overactivity. Also, one could activate the baroreceptor reflex to correct for both the sympathetic and parasympathetic nervous system dysfunction, and correct for any dysfunctions in the baroreceptor reflex itself. One could also use renal denervation, which is to reduce cardiac sympathetic overactivity activity via the nerve that ties the heart to the kidneys. So vagal nerve anatomy. Basically, the vagal nerve is a mixed fiber nerve. It has afferent fibers, which are sensory receptors that control the upper airways and the ear. It also has afferent fiber visceral receptors, which control for aortic bodies, arch, thoracic, and abdominal areas. There's also the somatic motor fibers, which innervate muscles in the upper airways. And finally, there are visceral motor fibers, which innervate the cardiovascular, respiratory, and gastrointestinal systems. So vagal nerve stimulation can be used for heart failure, as in the rationale of this is that increasing the sympathetic nervous system activity and reducing or decreasing parasympathetic nervous system activity input to the heart can lead to heart failure. Increasing the parasympathetic nervous system activity through exercise and direct vagal stimulation can prevent arrhythmias, or as in when the heart beats but not on time, and it can help prevent sudden cardiac death.
Fibrillation is a type of abnormal heart rhythm, arrhythmia, of your heart. Atrial fibrillation starts in the upper chambers of your heart, the atria, and causes them to quiver, fibrillate, instead of beating normally.
Vagal stimulation prevents ventricular fibrillation after myocardial infection. This
decreases
mortality. Cardiofit system is to induce the vagus nerve stimulation, which senses heart rate, and it stimulates the vagus nerve 70 ms after each atrial contraction. The stimulating system, however, is programmed to make sure the heart rate doesn't fall too low at less than 55 beats per minute. Phase 2 feasibility study of heart failure. So there's been a study on individuals with asymptomatic mild or moderate heart failure, and this can consist of symptoms like shortness of breath or right up to where individuals can't walk without noticing irregularity of the heart rate. Study 1 of this particular study found that devices were deemed to be safe and efficacious. So these devices that stimulated the vagus nerve were found to not be deadly. And study 2 found that 32 patients with LVEF who had less than 35% had reduced heart failure and increased quality of life. LVEF stands for left ventricular ejection fraction, and this is basically the amount of blood that exits the left ventricle of the heart. So moving along, the study went into its next phase, whereby in the event of heart failure, the devices innovated them. So 707 patients with moderate heart failure and LVEF of less than 40% were tested, and it was found that vagal nerve stimulation reduced symptoms of heart failure, improved the quality of life, but is not effective in reducing the death rate. So the death rates do stay the same. Reducing the sympathetic nervous system postganglia input to the heart improved autonomic control of the heart rate, but an anesthetic block of this had variable success. Breathing can change heart rate, producing heart rate variability. Heart rate variability measures the parasympathetic nervous system, or HF, and sympathetic nervous system, or LF, which affects the heart rate. LFHF is the sympathovagal balance. Through optogenetic inhibition of the stellate ganglia, it can reduce the sympathetic tone and thus correct for LFHF. Baroreceptor activation therapy, or BAT, is the use of electrical stimulation of the aortic depressor, which mimics the baroreflex and thus brings a decrease in the sympathetic nervous system activity via the RSNA, and as a result decreases the heart rate, decreasing blood pressure, MAP, etc., etc. It is used in individuals with LPK kidney disease, obesity, since leptin reduces the baroreflex, and micro-injection of leptin into the nucleus tracts solitarius affects the RSNA, heart rate, and blood pressure. Also, electrical stimulation can be used for called individuals with resistant hypertension. So this is when individuals have fast heart rate, high blood pressure, and I'm pretty sure this causes like very painful headaches that can't be reduced, as in can't be stopped, hence the reason why they're called resistant hypertension. It consists of when individuals have blood pressure greater than 140 to 190 millimeters Hg, despite the use of 3 or more antihypertensive medication. As a result, individuals with resistant hypertension are 3 times more likely to experience cardiovascular events. There has been BAT, as in Baroreceptor activation therapy, preclinical data, which was tested on dogs with induced hypertension, and it was found that using BAT reduced blood pressure, heart rate, and plasma noradrenaline, thus possibly serving as a treatment for humans. The high blood pressure, however, rebounded after ending the BAT therapy.
CVRx Rheos system, baroreceptor activation. Use a pulse generator similar to a pacemaker. Has 2 leads wrapped with carotid bulbs shaped like hands.
The next subsequent study relied on device-based therapy in hypertension trial, or DBUT-HT, and basically there was a pulse generator in 45 resistant hypertension patients who were followed over the course of 2 years. The device was found to be safe and efficacious, which reduced the blood pressure by 33 plus minus 8 mmHg. Rheos pivotal trial was the next subsequent trial, which had 265 resistant hypertension patients, and they were placed in a double-blind experiment for 6 months initiation and 12 months response. Individuals, however, failed to show short-term safety since 68 procedure complications had occurred, and it wasn't efficacious at all since there were no significant differences with the control in 6 months. There was, however, a reduction of blood pressure in 50% of patients, whereby they had less than 140 mmHg, but after a 5-year follow-up, 40 had their average SBP reduced. The final experiment I'm going to mention is about renal nerves, which are afferent or efferent nerves of the kidneys that influence blood pressure, and they consist of RSNA to increase renal vascular resistance, producing renin release, and increasing sodium and water retention. So this increases the retention of salts and water into the blood system instead of the usual expelling it through the kidneys and into the bladder. Basically, there are excitatory reflexes, which is the afferent system, which increases the sympathetic nervous system outflow to other vessels. So RSNA stands for renal sympathetic nerve activity, which I should have mentioned prior, and this correlates with resting blood pressure. Higher blood pressure implies higher sympathetic nervous system activity. There are renal afferent nerves, which causes an increase in blood pressure by activating the central nervous system region that controls for blood pressure. There is also renal denervation or surgical sympathectomy, which reduces blood pressure in individuals with resistant hypertension, and preclinical data illustrated that resistant hypertension was correlated with noradrenaline kidney content. Simplicity HTN1 was a study which showed that renal denervation was safe and it reduced resistant hypertension. HTN2 found that 40% of patients had systolic blood pressure 6 months post-procedure. HTN3 had a sham condition, and as a result, it failed to show clinically significant effects, since the sham helped to control for anything that might otherwise just be accounted by a placebo. So what went wrong? Well, this study probably was not effective due to inexperienced cardiologists, since it relied on a double-blind study. This had reduced procedural efficacy, and it was hard to get additional support. Renal denervation reduces blood pressure, inhibits both renal sensory and sympathetic nervous system.
So in conclusion, we looked at neuromodulation, we looked at the autonomic nervous system, the parasympathetic nervous system, and sympathetic nervous system. We also looked at the problems in heart failure, whether it be from arrhythmias, stroke, hypertension, and so on and so forth, many autonomic dysfunctions. We looked at optogenetics briefly, and how that could be used to stimulate certain fibres. We also looked at things like vagal stimulation, stellate ganglionectomy, baroreceptor activation, renal denervation, vagal nerve anatomy, which consisted of the afferent fibres, somatic motor fibres, visceral motor fibres. We looked at at fibrillation, Cardiofit system, phase 2 feasibility study of the heart rate, the Innovating of Heart Failure trial, Baroreceptor activation therapy. We also looked at resistance hypertension, BAT preclinical data, device-based therapy in hypertension trial, the Rheos pivotal trial, renal nerves activation, renal sympathetic nervous activity, and yeah, so we looked at 3 studies, either activating vagal nerve or the baroreceptor activation therapy or activating renal nerves. And we saw how effective they were. As in, at first, all of them appeared to be effective, but then controlling for placebo and whatnot, they weren't as effective. And thus this kind of hinders future research into this area. So yeah, thanks for watching. Join me next time whereby I'll talk about the translation of experimental neuroscience to clinical applications. So yeah, bye-bye.